Right.
All right. There's the information. Catherine, thanks for sending the group me.
Monica, do you want to mute?
All right, I'm gonna start at 5:10. Are all the faculty on here that are presenting? Ms. Dickerson, Ms. Pezos, Ms. Jean,
Miss Pezos is
Dr.
having
Udo, and
trouble.
me. Who is?
Miss
Pezos?
Pezos is having trouble.
I texted her
Yeah,
okay,
I'm
sorry.
working with her. Okay. All right.
And Dr. Wiggins is not present. All right, everybody. Good afternoon. Thank you all for joining us. I am sorry it's so late, but we're going to go through this. Feel free to ask questions. Some of us have questions to post. I'm going to go over the blood and blood products article. So I wanted to reiterate with everyone, if you haven't read it on the discussion board, there's 3 instances where you completely disconnect the blood transfusion. The first is for the hemolytic reaction. That's what occurs within minutes. And you disconnect and start a brand new infusion, new tubing, everything. The second one is with the bacterial, when the blood products are contaminated. You don't want to keep infusing that because it will render the patient septic, okay? The third time you stop a transfusion is when it's a allergic reaction to the extent of anaphylaxis, okay? Other reactions, you may slow it down. Some of the reactions are delayed. So right now I'm going to look at this article. If those of you who are following along, I'm going to go, hang on one second. Let me thumb through this.
Just a reminder for anybody who's not muted, can y'all please mute? Specifically, I have Jasmine that's showing that not muted on my screen.
I think there's a way that I can mute people, but I'm not sure.
Yeah, you just go to audio and hit mute all.
I can't.
I think that fixed the problem though.
I don't see that on my phone.
Well, you're not going to have the option. A host has the option.
Oh, okay. I just wanted to be sure.
Yeah,
you can't see me, right?
I can't find it. All right, you guys. If you turn to page 176 in the article, okay, we're looking at hypothermia. It's not testable, but when you're infusing blood and blood products and they're cold, the patient can become hypothermic and all the cardiac issues that entail from that. So that's the reason you do a blood warmer. Use a blood warmer, okay? It's a significant factor in survival, multiple adverse reactions, all right? So next on the list on page 176, I'm gonna go over allergic reactions. Clinical severity of allergic reactions ranges from minor itching and rash to anaphylactic shock and death. Most urticarial reactions are mild with hives and itching. And so what would you give for that? diphenhydramine, any kind of antihistamine. Remember, antihistamines dry people up. That'll come into play with mobility and myasthenia gravis as well. Okay. I'm turning to page 178 in the article. Coagulopathies happen when you're mixing multiple transfusions and bloods. The coagulation factors can become mixed up. There could be issues. It's a dilution of platelets. Usually that's massive transfusion protocol. All right. Page 181. Hemolytic transfusion. Sarah, did you have to say something? Thank you. Hemolytic transfusion reaction, that's within minutes. That's mismatched blood. The most frequent cause are human errors. In this article, it says 1 in 25,000 blood reactions. This occurs. Those have been proved to 1 to 75,000. Remember, this article is from 1998. These acute hemolytic transfusion reactions can lead to death. All right. The next one on the list in page 181, transfusion associated graft versus host disease. This is not something that's going to occur when you're starting a transfusion. This may be days to weeks delay. So you may not know this is happening until after the blood has long been transfused. It can happen in GI system distress. Treatment of the patient will be delayed. On page 182, febrile non-hemolytic transfusion reactions. Antipyretic therapy is the intervention. Aspirin or acetaminophen. Okay, this is for patients who develop fever post-transfusion. Okay, down page 182, hypocalcemia, rapid transfusion of large volumes. The citrate binds to calcium. Okay. And then transfusion-related lung injury, acute lung injury, can occur within 2 to 4 hours after initiating the transfusion. Respiratory distress, hypoxemia, hypotension, and fever. So treat accordingly. Diuretics mainly. Immunosuppression, this can happen later. Now, in this article, they don't mention TACO, transfusion-associated circulatory overload. That is a more recent concept that has come up. And that's non-cardiogenic circulatory overload. So diuretics slow down the rate of transfusion, limit any boluses, etc. So there are some infectious complications, but not as dire because blood screening has improved. Cytomegalovirus, hepatitis, etc. So I'll open the floor. If anybody has any questions, please feel free to ask. You can type it in the chat.
Thank you.
Anybody?
I don't see any questions in the chat, Michelle.
Okay. Please review the discussion board. There are a lot of questions that may be helpful. Go ahead, Dr. Udo.
Okay, so this is from Raven. Dr. DeLima, could you please go over your definition of mild to moderate symptoms versus severe?
For which issue?
All right, so Raven, I'm going to need to clarify that in the chat for TEALI and TACO.
For
Trailing
trailing?
and TACO.
I had answered that in the discussion. Mild to moderate, you might have some heavy breathing, maybe a little frothy sputum. You would give the patient maybe some Benadryl, maybe a breathing treatment. But the main issue is if the patient's oxygenation status collapses, which I put in the discussion board, the patient may possibly need to be put on a ventilator. So mild to moderate for taco, you would slow the transfusion down. But if the patient starts having bounding pulses, JVD, etc., headache, patient would get diuretics for that. And of course, slow it down. If it's a severe reaction, you call the healthcare provider. They may want to stop the blood. Okay. Realize that these reactions don't happen all the time, but knowing how to, the trick is knowing to keep an eye out on these occurrence of these problems.
Okay, we have another question, Dr. DeLima, from Kellyanna. It says the febrile reaction is one we can give Benadryl beforehand, correct?
Not necessarily. Usually a febrile reaction is a reaction to the antibodies, and it's hard to anticipate. So you would just give acetaminophen. So I had put that in the discussion board, is to consult your hospital policy for blood transfusions. Many facilities give diphenhydramine before a blood transfusion, but for this class, I'm not going to expect you to know that for testing, because every hospital is different. Okay. I did want to say, Dr. Udo, how do I share my screen with you? How do I make you a co-admin so that you can do the handouts?
I think I have a share screen button. Want me to just test it out and make sure it works for me?
Yeah, that's fine.
Share screen. Oh, host disabled participant screen sharing.
In order to enable the share screen, Dr. DeLima, if you go to more, you have an option to allow all participants to share, and that will give Dr. Udo the availability to share.
Can you, that's not coming up for me. I might have a different version than yours. Are you
should
able
have
to
the same,
share
so
your
click
screen?
more,
I did click more.
and it doesn't have the button or where your share screen button is there. I mean, I do this every day in my own Zoom calls, so.
Yeah.
Yes, I'm going to go over the chat. Diuretics for taco. Kalina, I had answered your question about Benadryl. That's not testable because that's dependent on the hospital. You can do diuretics for taco. Fever before the transfusion. Yeah, I'd probably call the healthcare provider. LPNs, for this class, since not all hospitals have the same policy, I go with don't transfuse. Go with an RN or a healthcare provider for checking the blood in. Let's see. You can give famotidine for allergic reaction as well as Benadryl. There are some other medicines, but just no diphenhydramine. Chance, yes, hypocalcemia. Usually that's not going to show up until the next day, or if it's a massive transfusion protocol. Bacterial reaction, yes, stop the infusion. You'd have to culture. All right. Dr. Udo, did you test sharing your screen?
It's not happening. It says that the host disabled participant screen sharing.
Okay. All right. I think I found it. I put all participants, so don't share. Just let Dr. Udo try it now. Dr. Udo.
Okay. Yeah. It's gonna work.
All right. Does anybody else have any questions? If the patient's having bronchospasms, yeah, probably so.
I thought for bacterial transfusion, you had to you could give the gram-negative medications that target gram-negative bacteria, or no?
Well, you still would have to get cultures first. But the gram-negative bacteria, I just mentioned that in passing. Usually that's the culprit. And then you would have to consult with the healthcare provider. So probably do broad spectrum antibiotics. So, all right. Any other questions about blood transfusions? I think the discussion board is open until noon tomorrow. So thank you all for coming.
Thank you.
Thank you, Dr. DeLima.
Thank y'all. Good luck.
Thank you.
Thank you, Dr. Lima.
Thank you, Dr. DeLima. So, who wanted to go second?
Me? Hi. Okay, I need to share the screen, so let me see if I can pull it up and share. Show.
Can everybody see the share screen?
Yeah.
Yes.
Okay, so I have a few application questions here. Can you all hear me?
Yes.
Yes, ma'am.
Thank you all, first of all, so much for coming. And hopefully this would help answer the questions. I know you all are gonna see me tomorrow. And I also gave some definitions of things you may not know already. So here we go. All right. You had a paper that I'm asking you to bring to class. It has barrier on it, it has strategies on it, and it has outcomes. So you're going to bring that to class to do a critique. Now let me see if I can get this out of the way. There we go. So I want you to read the question. And I want you to remember what barriers are. What look like barriers to you all here? So I'm not going to read it out to you because you can see the question. And I can't read the screen right now. I mean, the chat right now. So, if some of
Probably
you wanted to
defensiveness.
say the answers, that's fine with me.
Zoom call study session.
Defensiveness.
Defensiveness, great. What else?
Conflict.
Conflict. What else? I thought I heard somebody say
Consistency in the team membership.
right. I heard
Team
somebody
membership.
say it, but it's kind of garbly. But okay, very good. Why did you not say call out? What is call out?
Isn't it just like when you're repeating back to the doctor the order or something like that?
Tools of communication.
That's a check back.
Yeah.
Yeah. A call out a lot of times, make sure everybody's on the same page. Sometimes a call out could be done if somebody say, I think you're about to cut the wrong leg, then everything stops. So that's the reasoning for that. So your correct answers were A, which is conflict, because with the two nurses arguing, that's a conflict right there. The role clarity, the reason I put role clarity here is because they're having a disagreement about reassignments. Whose turn it is to get reassigned. You're going to have those type of things for real. Defensiveness, just be on the defense as far as maybe not agreeing to disagree. And of course, because I got reassignment in here, if you look at it, because I got reassignment in here, that might be an inconsistency in the team membership. So you all did great with that one. All right. So this one, I'm going to do a tad bit of teaching with it because I realized you hadn't had this lecture yet. So this is a rapid response. It's usually an activation for critical care experts to the bedside whenever a patient begins to show signs and symptoms of decompensation. And there are criteria that's set for that, but each hospital will set their own criterion. Now, a lot of times, worry about the patient. If you got a gut feeling about your patient and something just not right, a lot of times hospitals will tell you to go ahead and call a rapid response. These are the criteria that are set up for rapid response. I put something on soft chalk where I put it on where it's got an activity, and it also has this, and I think it has flashcards. So the next question has to do with this. It'd be lovely if you get it right, but if not, I understand. All right. Look at it. Look at what you got here.
C.
I will say a new.
A,
I'm
I
gonna say
like
A
C.
too.
C.
I like C.
Say A.
What's the difference between C and A?
C and A. A is a
ABC.
new onset of difficulty in speaking, meaning there's some
Okay.
kind of change in their mental status.
Airway, breathing, circulation.
Yeah.
All right. So C is the correct answer. The new onset difficulty speaking is more or less a stroke activation. That's slightly different because you got stroke activation, you got code blue, and you also have rapid response. So let me go back. These are the criterions for the rapid response. Even a change in the conscious state. Now, sometimes they might really call a rapid response instead of a stroke activation. It's very good to call stroke activation if you know that your patient is having a stroke. You call immediately because they got a timeline to get things done. So, okay. So the correct answer for that one was C, because it's less than 90%.
Ms. Shawn, should we know that criteria for testing purposes?
For nursing purposes, yes.
Okay,
All right.
thank you.
Oh, you're welcome. All right. And there's the rationale.
What type of response there? Stroke, code blue, rapid, and what was the other one? Or am I making one up?
Code blue, rapid response, stroke activation. And I'm sure there is another one, but I can't think of it right now. But in this particular scenario, what I have as your distractors, this is stroke. This is somebody that just a little exhausted after they ran, so there's no reason to take care of them. This is a person that has a really good heart. He's got a 97% saturation, eyes closed, so it's probably nothing's going on with him. All right.
Thank you.
Thank you. All right, this next one. How do you think this person's feeling?
Angry.
Angry.
Yeah, let's say you can't hear them, but you could see them. They're angry, right? Well, nonverbal communication is something that's going to be tested as well. Being able to perceive this person by looking at their actions. Looking for nonverbal. This person looks pleasant, look like somebody's approachable, that you can, oh, don't start now, please don't start now. That's pleasant, look like they're approachable, look like you could teach them. So just be mindful, meet people where they are. If the person is a little angry right now, give them a minute to cool off. Can you tell how this person is feeling?
No.
Not really. And the reason you can't tell is because when we write, when we send emails, we have a chance to do it over and over and over again to improve on what it is we want to say and how we want to say it. So a lot of times your nonverbal communication is speaking a lot louder than when you write, you send emails. You don't really have a chance to think. Okay. Now, this is another one that is kind of a teachable moment right here. Mutual support. And that's kind of a backup like behavior, meaning you're supporting your team members, assisting one another, providing and even receiving feedback for performances. You're also that advocate for that patient. You have to be an advocate for the patient because team steps is about patient safety. And remember, you're the nurse. You're going to speak up for that patient. If you're in a multidisciplinary team round or whatever, you're the one that have to give all of the report and collaborate with your team members so that they'll know how to take care of a patient. So that's ultimately your duty because nurses are at the bedside 24/7. All right, so this is a question about mutual support. What are we thinking?
Anticipate the need. B.
I like that answer. Okay. You're going to anticipate the need because you want to ease that workload because you remember I said there, you're advocate for the patients, but you're also supposed to have a mutual support for your colleagues. So out of the choices, that would be the best choice. And your rationale, this is your rationale. I'll leave it for a minute, snap a picture, do whatever you might want to do with it. But B is correct because you're anticipating the needs, and it is a method that's used to show support for the staff and help to ease their workload. Okay. Okay, I'm gonna stop sharing. I think that was the last one. So I'll take any questions.
That was great.
Thank you. Now, just a reminder, there is a recording and a handout and an activity, and I also have 2 videos. We're going to discuss the longer video in the classroom, but we'll I also put the one that's done properly. I put that up there as well. So I believe you'll be okay. So Dale, I see your hands up. No, you're yeah, the hand, what kind of hand is that? The automatic hand, you know, the one that
A little cartoon animated hand.
Yeah, but that's all right. It's gone now. No problem. It's okay. It's okay. All right. Do you have any questions? Looking forward to seeing you all tomorrow. And hopefully that you already used, thank you, Joanne. Hopefully you've already used, you know, the information that's up there. So, you know, you'll be on target tomorrow. Thank you.
And thank you,
Don. Thank you.
Thank
All
you.
right.
Thank you.
Thank you.
No problem.
Thank
Thanks.
you, John. So who wants to go next? We got Teresa and Sherry.
I'll go next.
Okay.
You can hear me?
Yes.
Okay. I'm gonna share my screen.
Okay, good. I can see your screen.
Let's see, I want to get, okay. This is just some of the things we touched based on in lecture, spinal cord injury. We talked about spinal shock. And the cues regarding those, neurogenic shock, log rolling, complete versus incomplete spinal cord injury. Some of the psychosocial effects, we touched on autonomic dysreflexia, Guillain-Barré syndrome, myasthenia gravis. So I'm going to put up this question.
A.
So what are your thoughts?
I'm gonna say A too.
A.
A.
Hey,
A, the patient diagnosed with a C6 spinal cord injury who's describing dyspnea symptoms and has a respiratory rate of 12 per minute, 12 breaths per minute.
Or C.
Okay.
I
So the
say
patient, I'm sorry,
I'm gonna say C.
C. Okay, what made you choose C?
Headache and feeling hot all of a sudden.
Okay, but you have, but look what's in what you're given, an L2 injury, lumbar 2 injury. Are you thinking in terms of autonomic dysreflexia?
No, because it's not T6 and above. That's L4.
Right, it's not T6 and above. So that's what would make C wrong.
Yeah. So it's A.
So A, that's correct. The patient diagnosed with dyspnea, respiratory rate of 12, that has signs and symptoms of a respiratory complication should be assessed first. Because any paralysis at the C6 level could cause the patient to stop breathing. It's affecting the diaphragm. Any questions about that?
I have a question.
Yes.
If we had the same question, but C was above T6, which would the answer be?
Then C.
So C would trump A.
If you had the same question with the same choices?
If we had the same question, same choices, but C instead of L was the T6, like T5. Would C be the answer?
Well, A has to do with airway, so airway.
Okay.
Airway first. If you had a choice with C being T6 and above, then I would choose airway. With this question. Any questions about that? Any thoughts? Everyone okay with it?
Yes, ma'am. We good.
Okay. Okay, next scenario.
D.
D.
Yeah, D.
D, exactly. Ineffective breathing pattern. Patients with Guillain-Barré and ascending paralysis. And, once it reaches the diaphragm, they could run into problems and need to be intubated. So D.
Would the second priority be A?
The second priority,
Yeah, like if D wasn't an answer and D was like a ballpark, like something that's obviously wrong, would it be A then?
decreased cardiac output. I mean, no, I would say no.
Right, because
That
the biggest thing about Guillain-Barré is that airway respirations being lost due to the paralysis of the diaphragm, right?
exactly, because it's an ascending paralysis
Mm-hmm.
from the bottom up. So the
You're gonna
diaphragm is
where anything happens to your heart because it's going up, it's going to hit your lungs.
right. It's right. It's going to hit the diaphragm, and then you're going to run into problems and need to be with breathing and need to be intubated.
Okay, thank you.
You're welcome. And of course, they're going to be fearful and anxious, but the priority, of course, is getting them maintaining their breathing, intubation.
Ms. Bezos.
Yes.
For that one, you said in class that usually like 1 to 3 weeks before they get the Guillain-Barré syndrome that they may have had like a bacterial or viral infection. Are they progressively getting worse over these 3 weeks so we could catch it early, or is it kind of like a drop moment where it just happens?
It's in acute ascending paralysis, so it's happening. I don't think in this process it's going to be 1 to 3 weeks. The virus is something separate that they see when you're asking the patient about their history and what's going on, what happened to them, how did they get to this point? So look at that as something separate. So 1 to 3 weeks before they have had all of that GI, viral or bacterial, some type of infection that occurred that kind of sent them into this process.
Okay, thank you.
You're welcome. Anyone else? Okay, with autonomic dysreflexia.
D.
D?
Yeah,
D.
D.
check the bladder.
Palpate the client's bladder. That's correct. The most common cause is an overdistended bladder. So you're going to do palpate the client's bladder first. Overdistension, then you would insert a urinary catheter based on your findings. You don't need to place the client intra-Nellenberg, and there's nothing to indicate that you need to complete a neurological assessment.
And Ms. Pezos, Tammy is in the chat. She just said preferably set them up. So if that were an option, of course, that would be the first thing that we do. But knowing that the first thing out of these options would be assessing the client bladder, correct?
Right, D, exactly.
I know you can't see the chat, so I was just making sure.
Yes, I can. Thank you for letting me know. Any questions about that?
Wait, I do. I have one question.
Go ahead.
On top of assessing the client's bladder, I remember you saying that the second common cause would be like a fecal impaction or like buildup of poop. How would you assess for that per se? Or would you be worrying about assessing that in this type of situation?
I mean, 85% of the time it will be an overdistended bladder, or if they do have an indwelling catheter, like I was saying, you just check for kinks in the bladder, look at everything towards the bladder first. Unkinking the indwelling catheter, or maybe it's clogged, maybe you need an order to flush the catheter. but check with that first, because 85% of the time it's going to be something related to an over-distended bladder, whereas 15% of the time it would be a fecal impaction. But I would definitely assess the bladder first, because
Thank you.
relieving, like I was saying, relieving that pressure alone can start to relieve their symptoms of headache and start to help the blood pressure come down.
Okay, thank you.
You're welcome.
Did you say we would need a order to flush the bladder?
Yes, I mean, if you're seeing that nothing is going on, or you suspect maybe the indwelling catheter is clogged for some sort of reason, then yes, you would have to contact the healthcare provider and update them on this condition as to what's going on.
Okay.
And someone asks, would you give a KUB for bowel impaction verification? So I'm assuming like a X-ray.
You could, yes, you could get an order for that. Definitely, that would show if there was an impaction. Definitely. Any other questions? I can't see if there are.
No more.
Okay. All right, we'll move on to a question about myasthenia gravis.
Would that be speech therapist?
I would say speech therapist.
That's
Jesus,
correct.
can you go back to,
I'm sorry, say it again.
can you go back to slide 8? Like I knew the answer, but I just wanted to see the rationale.
Oh, sure. We'll go back. Go ahead.
Got it. Thank you.
You're welcome. Anyone else? Okay, here we go. I heard someone say speech therapist.
Yes.
Yes, ma'am.
That's correct.
If this was a select all that apply, if respiratory was on here, would that be okay too?
If it was a select, I'll apply with respiratory therapy.
Yeah.
I think that they can experience some respiratory failure with myasthenia gravis. That could be a possible choice that I would consider. But yes, I want you to be thinking in the direction of speech therapy, because remember, they have this skeletal muscle weakness that can interfere with difficulty swallowing, difficulty chewing. So definitely speech therapy would play a role in whatever it may be, changing their diet to help them accommodate what's going on physically in their body.
Thank you. I
You're
think I
welcome.
got confused.
Okay. Is that a question? And I'll help put up this for you. And that's what I was mentioning about the medication and the importance of taking the medication 30 to 60 minutes before eating to help them, so they won't have that muscle weakness as much when they go to chew and swallow. Okay. That concludes my review of questions. Anything else?
Thank you, Ms. Paisley.
Thank
Thank
you.
you.
Thank you. Thank you for attending. You're welcome.
Miss Pezos.
Yes.
I just had a question about the Halo external fixation device. I asked it on the discussion board, but I figured I'd ask you here. You
Okay.
said wait, what?
Go ahead.
You said something about rolling onto the side and pushing on the mattress with arms. What is that for?
I think that's just to get them, to push up, to be able to sit up, to
Okay.
assist them in sitting up.
And then with the wrench, having to have that at the bedside in case the patient needs CPR, is that something that we're gonna do, or is that a doctor thing? I just wanted to know that for me.
Yeah, I mean, I would ask definitely with anybody that has some sort of device, if you have something that you need to be able to unlock it, unscrew it, anything, I would find out maybe the wrench comes from the manufacturer or whatnot. Somebody should have that present, because if you need to give CPR to the patient, you need to have access, at the
That's
at the
something.
bedside for it.
Is that something we do, or because it has traction and weights, or is that not in our scope?
No, it's just you can have it at the bedside, just like having an intubation tray or, anything like that. I'm trying to think who you would get that from. I would imagine they would have access to that in the kit or something where the Halo vest, where whoever put the Halo vest on should have access in the kit or something like that to it.
So I think what she's asking is who unscrews the traction, the nurse or the doctor, like not in an emergent situation. I think just in general, right, Catherine?
Yeah, just because our scope of practice is very
I understand. Limited, yes.
yeah.
That would be definitely something to ask the physician or ask the charge nurse. Somebody would know. If you receive this patient, I would want to know where can you get access to that?
Thank you.
And who does it? I would ask if I received that patient, I would ask, where do I find this and where can I get it and who's allowed to unscrew it in cases of CPR? Does that answer your question?
Yes, thank you.
Okay. Anyone else?
No, thank you.
I don't see
Okay.
anything else in the chat for you. So you'll just have to unshare your screen and we'll move on.
Okay, thank you all.
Yeah.
Thank you.
Wait, did she leave? Wait, don't.
No, I'm still here.
Okay. I wanted to just make sure you unshare your screen.
Stop sharing. Okay.
Yay. Okay. So who's left? Teresa? Are you still with us, Teresa? Did we lose you? Teresa Dickerson?
You want me to send her a text?
I guess so, because she was on the phone. She made it in here, didn't she? Into the new one?
I sent her the login. Let me send her a text.
Okay. I'm happy to go ahead and start if it's just
Oh,
me.
she's there. She texted me. She's on mute.
Okay. Well,
Thank you, Ms. Dickerson.
You can have the floor, Teresa, if you'd like.
Do you want to go next, Ms. Dickerson?
If you're talking, we can't hear you, Teresa.
I sent her another message.
All right, I guess I'm going to move forward, Michelle. Okay.
Oh, wait, no, I have her on mute. It's my fault. I'm
Okay. Okay. Hey, we can hear you now. Uh-oh.
I have to find her number.
I can call her.
Dr. Delima, she's the only person on the phone. If you scroll all the way to the bottom, she's the only phone number.
Thank you, Kelena.
So yeah, I just got a pop up saying Dr. Delima would like you to unmute.
Asked to unmute. I don't know if I can unmute you, Mrs. Dickerson. Because I'm trying to unmute you, and maybe because you're on the phone. I don't know.
Who's that?
Yeah, it did pop up, Dr. Delima, to ask me. They said you asked us to unmute. So if she's on the phone, she may not be able to see that message. I'm not sure.
You
Yeah,
might be able to unmute her, Ms. Shawn or Dr. Udo, because I gave everyone permission.
Yeah.
I think I maybe it's my laptop.
Well, while she tries to get connectivity, you want me to just go? I'm gonna go. Teresa, sorry if you're trying to get on. Give you time to figure it out. I'm Dr. Udo, and I'm gonna go ahead and share my desktop. There. And what I want to share. Okay. So hopefully y'all can see my slides called infection, putting it all together for test 4.
Can anyone not see her slides? Just put it in the chat.
Okay. So I do want to start off by saying that I did get, I've gotten so many emails asking questions and the discussion board that somebody said, sent me an email saying, could you please ask, application level questions? And so I was like, well, these questions that I pulled up in class are at the application level. So this was like one that I asked, and the nurse has to plan a care for a patient ICU with sepsis to prevent post-ICU syndrome. What should the nurse include? And I asked y'all just to fill in the blank. Now I've made a new question to follow this, but if y'all can just, some people turn on your
No diazepams.
Avoid
right? No.
diazepam.
Sleep protocols.
Close the
Reduce
window. Promote
Shades.
sleep.
Hearing aid.
Glasses.
Close the door.
Use your red light when you go in as a nurse at night.
Ambulation.
Yes.
Them up in the chair.
Prevent
Use assistive
dehydration.
devices if they wear glasses, hearing aids.
Orient them to daylight, night and
Open
day.
the shades up in daytime.
Be quiet at night.
Exactly. So y'all just made all these. Yeah, I would have put a check by everything that you said. What if I said, give Valium or give, diazepam?
No.
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 Benzo.
Right.
No benzos.
Right. No benzos of any type. Right. Very good. So another application question is, what should the nurse do to prevent post-sepsis syndrome? So A, B, C, or D. Keep the overhead lights on bright all day and off at night.
D.
D.
Okay. So y'all saying D is in dog?
Yeah.
Yeah.
Yes, mobilized.
Mobilization. Yeah, to the highest extent they're capable. Yeah, that's going to make them so much better, so much quicker than. And now, what makes A wrong? Keep the overhead lights on bright all day.
D and off at night. I mean,
Yeah,
Too much stimulation.
Yeah.
Periods.
I agree. It's too much stimulation. You have those fluorescent lights on all day and they're facing straight up into them. You know, it's almost cruel and unusual punishment. So what about keep the noise level between 35 and 100 decibels on the unit?
It should be less than 35.
Way less. Yes, it should be less than 35. 35 to 100 is how noisy we usually are 90% of the time. So, you know, no, that's way too loud. So we put a big line through that. And then what about keep their eyeglasses secured in protective case to decrease damage?
That's not allowed them to see.
No.
No, put those things on, right? Because the question is, what are we trying to do to prevent post-sepsis syndrome? So locking the glasses up inside of a case, is that going to help? No, right? So always go back to the question, you know, and read the question, you know, in detail. No, those eyeglasses stored inside a closed case are not going to do anything to prevent post-sepsis syndrome. Okay, so that is an application level question. So, and this is a simple application question because I made the math very easy. Y'all should remember this from class.
The 3 liters.
3 liters.
Yeah. So the nurse admits the patient. Now, number one, we notice, what does the nurse have to do in order to give this bolus?
Weigh the patient.
Weigh the patient.
So that's gonna. So think about another test question. What must be done? You know, when
We got to get a weight.
Yeah, we're gonna have to get a weight. And if we're gonna give a bolus, what else has to be done?
IV.
IV. Yeah.
we gotta start an IV, right? So that, you know, so you're just like thinking like a nurse to answer the questions. Like, but from the stem of this question, I could ask, you know, a million different questions. You know, I could change the weight of the patient. Then what would the bolus be? Okay, so y'all have that. That's very easy. We talked about that in class. We talked about this one in class. After reviewing the bar of the patient in septic shock, which medicine should we give? So we're ordered to just give one. So which one are we going to give to the patient in septic shock?
Norepinephrine.
Yeah, of all these meds, and then why are we not going to give the furosemide continuous drip and titrate to their urine output?
We want to increase
It's a diuretic.
It's a diuretic. So why do we not want to diurese them?
Hypovolemia.
They're already hypotensive.
We need to increase their pressure.
Perfused, so they need.
We need to increase the pressure.
That's right. They're already hypotensive. If we diurese them, they're going to become more hypotensive. And someone else said we need to increase that pressure. So we're not going to say yes to the furosemide. And what about the dobutamine? Why didn't we say yes?
Only if there's a contractility issue.
Yeah, only.
Well, dobutamine would be like the last measure, right? If the norepi doesn't work, if the vasopressin doesn't work, then we will try to give dobutamine because maybe the heart is.
Output is affected.
And that's true, because when we see, after we hang the norepinephrine and we realize, wow, the patient isn't responding to this norepinephrine like I anticipate, right? So if they're not responding, then we start thinking, well, I wonder if they're also having a contractility problem. So the dobutamine could be something down the line, but if I'm asking you which one of these are we going to give now for this patient, we're going to do something to up their pressure, right? Because they're in septic shock, right? So milrinone, and you can just see in the orders here, the milrinone 50 mics per kilogram per minute over 10 minutes, followed by 0.5 mics per kilogram per minute, continuous infusion if the dobutamine is at the max dose. So obviously the dobutamine would have to be hung before we could even give the milrinone. So we're not going to give that now. And what about the nitroprusside?
No, that's vasodilation.
No, that's a vasodilator, and we would never give a vasodilator to somebody who is already vasodilated. We will kill them, right? So that's So now let's look at the same question and then just say, which one of these medications would cause the most harm to a patient, to this patient in septic shock?
The vasodilator.
The nitroprusside.
The nitroprusside, the vasodilator would kill them, right? And then if we made this into the select all the apply question, what medications could the nurse give to the patient in septic shock?
Dobutamine.
A and C.
A, C, and D.
So if we have somebody in septic shock, could we give norepinephrine?
Yes.
Of course.
Yes.
Yes, of course. Yes, of course. No, that's really, that continuous LASIK strip is sounding like somebody in a chronic overload position, you know? So we're going to say no to that. Could we possibly give the dobutamine drip?
Yes.
Yeah, we just said if they become refractory or don't respond to the norepinephrine, we might see maybe if we increase that cardiac output, increase that contractility, maybe we'll get that blood pressure up. And then the milrinone, could we possibly give it?
Yes.
Yeah.
Yeah. And could we possibly give the nitroprusside?
No.
No. Again, no. We've crossed that out with a big red marker a long time ago. We are never giving them septic shock, no matter what. Right? So we did the select all that apply, and the answers A, C as in cat, D as in dog, right? All right. And then again, the application of hemodynamics and thinking about the person in septic shock. So we look at our cardiac,
You would probably increase it because the SVR is low.
Sorry. So cardiac output is 4. The mean arterial pressure is 45. The systemic vascular resistance is 550. And the pulmonary capillary wedge pressure is 3. So first of all, we're going to just evaluate each one of these numbers. Cardiac output, what's the normal cardiac output?
4 to 8.
So we're low normal. MAP, what should our MAP be greater than?
65. It should be 70 to 100, but 65.
Okay. So yeah, so we are currently on that norepinephrine infusion because after the initiation of the infusion of the norepinephrine, we have now lowered our standards from a MAP of 70 down to a MAP of 65, right? So are we at our goal?
No.
No, we are below goal, and we are not sustaining, cellular perfusion, and we're not sustaining life at that. What about our systemic vascular resistance?
900 to 1200. So
14 is low.
Right. So it's low. So is our aorta and our arteries, are they dilated or are they constricted? Dilated. So is that pressure high or low?
The low pressure.
Okay. And what hemodynamic parameter does the SVR represent?
Afterload.
Afterload. So afterload, think of the aorta. A for afterload, A for the aorta. So that afterload, the load that the ventricle has to contract against to get the stroke volume out into the aorta. So does the left ventricle have a lot of resistance or a little bit of resistance? Or no resistance?
Very little resistance.
Very little resistance, right? And so because that left ventricle can eject a stroke volume against very little resistance, that's why we're seeing like a normal cardiac output, a low normal cardiac output, because the resistance, the afterload is so low. And then pulmonary capillary wedge pressure, what should that be?
2 to 6.
Pulmonary capillary
4 to 12.
12. Yeah, 4 to 12.
4 to 12. So what do we, but our pulmonary capillary wedge pressure is 3. So
Low.
that is low. So these are numbers that we see in somebody in septic shock. So let me just ask you one more. If they had a CVP, what do you think it would be?
Low.
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 Give me a number.
1.
1.
Yeah. Low, lower than normal. Right. Those are the hemodynamics that we expect. So if these are what we see in septic shock, what are we going to do to that norepinephrine drip?
Increase the rate.
Yeah, we're going to increase the rate, right? Because we're not perfusing. We need to get that MAP up to 65. Good. Now, I'm also showing this one that we reviewed in class as well, because I got, I guess, a message on the discussion board. And like, I definitely have to clarify this. Somebody told me on one of my slides, that I said to never infuse norepinephrine through a peripheral IV, so to give it intraosseously. And I didn't say that. That was one of my wrong options for a practice application question in class. So let's review the application question. The patient is hypotensive and the nurse is ordered to begin a norepinephrine continuous infusion. The patient has a patent 18 gauge IV. What should the nurse do?
C.
And
We're going to begin the confusion.
Started peripheral.
Started.
We're going to begin peripheral, but call for A line.
Yeah.
No, not necessarily for A line.
Central line.
Central line.
Right. So do I need, at this point, do I need to clarify this order with the healthcare provider?
No.
No, those orders are loud and clear. We're going to start them, right? Do I call for the central line to be inserted prior to infusing the norepinephrine?
You can do it after.
No.
You do it after.
Do it after.
Right. So we're allowed to go ahead, as dangerous as it is, to do the infusion through a large bore peripheral IV. But we definitely want to advocate for the safety of this patient. So we're going to ask the physician to give us orders for a central line and put those orders in so we can get somebody to the bedside to insert a central line. The central line will be inserted. And when we insert that central line, we're going to have to call a timeout, and we're going to have to do all the things that prevent a central line infection. Because they're already infected, we don't want to infect them again putting in a central line. So, but we definitely.
Excuse me, Dr. Udo?
Yeah.
You did have a question about the size. What's the smallest size for, what's the smallest gauge that you could use for peripheral?
So it says a large bore IV. It doesn't give us like the gauge numbers, but I'm going to make it, I would have, in my personal experience, large bore IV would mean something that you can give blood through. So what's that? 18, 20?
18 to 22.
What's that?
18 to 22.
18 to 22.
Yeah. So, and 22 if you're desperate. But the big important thing is to check for a blood return. And that's the problem with those little skinny 22s. Many times those catheters will collapse on themselves when you try to pull back and see, do I get a blood return? But in those 18s and 20s, you're more likely to be able to pull back and see the blood return. We want to make good and sure that if we're going to put this norepinephrine drip in through a peripheral IV, that it's in the vein and not infiltrated. And so unless you see like a blood return, you're not sure. So it's a big responsibility that you take hanging this through a peripheral IV. So you want to make sure that's a good IV. And then the last one says never infuse norepinephrine through a peripheral IV. So give it intraosseously, and that's a distractor. That's wrong. But yes, we can give it through a peripheral IV. The 2021 guidelines say, yep, if you have to rescue the patient, go ahead and do that. But we prefer to have a central line. So try to get, advocate for the central line and get the central line inserted. And once that's done, we'll get a chest X-ray, confirm that the central line's in proper place, and then we'll switch over that IV from the peripheral line to the central line. All right. So the only answer that is correct is C. All of these other ones, A, B, and D, were distractors. So y'all may have seen that discussion on the discussion board. So I just wanted to clarify that confusion. When you're reading the stems of test questions, hopefully the highlighter will be activated, and I just recommend highlighting anything that is unusual to be included in the stem, and anything that is wrong or action, a significant data that's going to play a role in how you answer the question. So anytime we put a weight in a stem of a question or age in the stem of the question is going to probably be pertinent to the question. Because we're not supposed to add ages, gender, weights, or whatever, unless it is needed data to answer the question. Let's see the okay. So, so as I'm reading along the stem of this question, patient is presented to the ED. They have community acquired pneumonia. The blood cultures were drawn. They were given these 2 antibiotics. Blood pressure is still low. And always calculate your map to see how low it is. And then we see that lactate is 6.2. Now, I will say on your handout where y'all memorized all those labs, for your y'all have on your lactate is 0.6 to a 2.2, and that's on your handout. And I tried very hard to have the lactate to top off at 2. But evidently the labs all came from your lab book. And so we had to go with those labs. So they just said, Kim, when you're teaching sepsis, you just have to let them know that when we're talking about a patient with sepsis, that if we see a lactate of 2 or greater, we're concerned about sepsis. And then, of course, if we see a lactate of 4 or greater, we're concerned of septic shock. And if we see a lactate of 4 or greater, we're going to bolus them no matter what their blood pressure is. So let's see, a 2-liter bolus of lactated ringers was administered. And after the bolus, we did an advanced assessment with a bedside ultrasound. And they can put like that little ultrasound Doppler on top of the left ventricle, and they can actually see what the stroke volume is, and they can see if there's vascular collapse. So they could see by doing that the stroke volume was not at 100%, it was only at 14%. So when we think about the volume in that left ventricle, is that volume high or low?
Low.
Low. It's only at 14%. At 100%, it's just right? So you can see, even though they've had a 2-liter bolus of fluid, now they did another assessment and we see, ooh, the stroke volume is still super low. what do you think that the healthcare provider might consider to be appropriate intervention?
Continue to bolus.
Yeah.
Give
Yeah.
me some
And
more fluid.
yeah, we all need to know that this patient needs more fluids. If the nurse was to suggest one other assessment, what might we assess?
Reassess lactate.
Okay, that's a good idea. After a bolus,
Their
we're gonna
map.
Passive leg
Do the
raise.
passive
leg
leg raises.
raise.
Right. Or map.
Okay.
Fluid.
So, map. So if we're trying to see, I gave them 2 liters, their stroke volume's still low. How can I tell if they're going to be a fluid responder?
Passive leg raise.
Passive leg.
Yes.
Passive leg raises.
Right. If we're trying to make a decision, do we give another bolus? Passive leg raising is a great quick assessment. Now, somebody else said lactate. A lactate is also a good idea. We normally see the lactates are really high. We give boluses. We'll follow up, a couple of hours later, get another lactate, and we should see that lactate falling, right? Now, later, next day, we're looking at our patient. We're like wondering, I wonder if they, need more fluid. Well, once again, we're back to reassessing them with the head to toe assessment, looking at our labs, passive leg raising. But that lactate is helping us too, because we want to try to get that lactate down. So as far as like determining fluid boluses, 2 things that help us really good on are they a fluid responder? It's that passive leg raise. And then I can't really say the lactate says that they're a fluid responder, but that high lactates say that they need, we're trying to normalize that lactate with fluid boluses. So to me, an assessment that is this patient a fluid responder, my first thought is we do a passive leg raise to determine if they're a fluid responder. And then, of course, then we assess them and use hemodynamics too, but classically, passive leg raising. So a resident was just admitted from acute care hospital where they were treated for septic shock from pneumonia in the ICU. The resident was moved to the med-surg unit and has a new delirium and now needs an assisted device for mobility. What should the nurse plan? And I've highlighted them. Lame. So we know that these patients that were in ICU have a large, huge chance of developing post-sepsis syndrome or post-ICU PICS syndrome. They're very much the same, the delirium, confusion, fatigue. So we're going to create a plan of care for that patient, thinking about post-sepsis syndrome and post-ICU interventions. We're going to talk to them about the delirium. We're going to help do things that keep them from becoming delirium. And then we're also going to talk to them and we're going to observe for post-traumatic stress disorder or triggering of it. Are we going to assure that benzodiazepines are ordered and on the MAR?
Absolutely not.
No.
Absolutely not. That's right. Big line through that one. Are we going to implement strict bed rest until the delirium is no longer present?
No, early mobilization.
That's right. We're going to dangle them. We're going to see, can you push against my hand, push with your shin, push against my hand with your shin? Do you look strong? Hey, lift your head up. Look at me. Now I'm going to get another nurse in there with me. So for safety reasons, one on each side of us, to get them up out of bed and kind of, take the little dance steps over to the chair and sit them down. They're going to do much better. So no, we're not going to implement strict bed rest. And then assess for cognitive function every 2 hours, 24 hours a day.
No, because you're not allowing them to rest.
Yeah. And normally our cognitive function, what assessment are we doing for their
CAM ICU.
well, yeah. And how often do we do that?
Once a shift.
Once a shift in the ICU. we're not going to have to be doing cognitive functioning every 2 hours. We're just, whenever your head to toe assessment is, that's when you'll assess for your cognitive functioning. Now, this patient, they're not in the ICU anymore, right? They just got to us from an acute care hospital where they were treated for septic shock. Oh, they're a resident. So we're in a nursing home, right? They're a resident. Right. So, yeah, we're not going to be doing neuro checks on them every 2 hours. So here is just a case study. We looked at this briefly in class. So here we have a 56-year-old male. They arrived from the ED to the ICU with septic shock. They were diagnosed down there in the ED with a urinary tract infection due to a blockage from a kidney stone. And down there in the ED, those emergency room nurses gave some acetaminophen. The ED nurse gave me a report that this guy's got a past medical history of an ejection fraction of only 35%. In his past history, he's been mechanically ventilated. They drew a lactate and they drew blood cultures down there in the ED and sent them to the lab. And down there in the ED, he received a 30 mil per kilogram fluid bolus and his broad spectrum antibiotic. All right. And now they've shipped him up here to the ICU. Now we're up in the ICU and lab has called and they've told us some lab results. And I've taken some assessments. So I took my blood pressure, which was 80/48, and my MAP is 57. So that's not good. The temperature is elevated, 101 Fahrenheit or 38.3 Celsius, right? When you talk about Celsius, you don't want the temperature to be above 38 or below 36. So we see fever. Heart rate's fast, the compensatory to the heart rate that goes with that low blood pressure of 120. We get our lactate. And what do we think when we see that lactate of 12?
Septic shock.
Yeah, horrible. Yeah, right. Just horrible, right? That lactate's very high. What do we think? And what do we think when we see our WBCs?
Elevated.
Yeah, this is clear leukocytosis with elevated WBCs. What do we think about the BUN?
It's normal.
Normal. I know. Yeah, I'm not worried about BUN. And that's really not part of my sepsis assessment, really. What do I think about the creatinine?
It's supposed to be less.
Oh yeah.
High.
Hi.
It's high. What's it supposed to be less than?
1.2.
1.2 in sepsis, right? Now I'm just going back to y'all's little lab sheet, and creatinine should be, what do we say, 0.5 to 1.2. Okay, so we want our in sepsis, we want our creatinine to be less than 1.2. All right, and so our creatinine's elevated. So what organ's being hypoperfused? The kidney, right? All right, and then procalcitonin. It comes back and it's 5. Somebody asked me on the discussion board, do we need to know the normal procalcitonin, that it's not on the lab sheet? No, you don't need to know the normal, but I can tell you that procalcitonin should be less than 0.5. What you do need to know is that procalcitonin is going to be elevated, like 5 is elevated, and it's going to be elevated when?
Bacterial
infection.
If we have a bacterial infection. Will we have a high procalcitonin with just a viral infection?
No, it doesn't show.
No. And then once we start hanging antibiotics, what will happen to our procalcitonin?
decreases.
It's gonna low. It's gonna normalize.
It's going to normalize. It's going to go down, right? So we can use procalcitonin to tell us, sometimes these patients are not really clear cut, and it takes a little bit longer to determine, is this sepsis? Is this just hypovolemic shock? So sometimes it's a little tricky. So we'll get labs like procalcitonin to help us decide, is it a virus or is it a bacteria? And then we also use it to determine, hey, can I stop my antibiotics now? Do I need to go in for a full 10 days, or can I stop after 7? All right. So what do you think that the nurse will do now? We just took these vital signs on this patient, and we looked at our labs. What do you think that we're going to need to do for this patient?
You're ready to hang the norepinephrine.
We're gonna give fluids.
Passive leg raise.
I would give another
I mean,
bolus.
a fluid bolus. Yeah, fluid.
Yeah,
refill.
because they already gave fluid in the ER.
We're
said
implemented
bolus.
that 1 hour bundle. That 1 hour bundle.
Okay. So you're all talking the right talk. We're all saying, well, they gave that first bolus down in the ED, but they didn't have their lactate back yet, right? Now the patients come, and I don't know how long they had them down in the ED. They may have had them down there a couple of hours. I don't know. But now they're up here with us, and now the blood pressure has obviously fallen, because if their blood pressure was that low down in the ED, they would have started a norepinephrine drip, right? Do y'all agree with me?
Yes.
Yeah, hopefully.
Down in the ED, they started implementing the 1 hour bundles. You can tell they told us he got his bolus and he got his 2 broad spectrum antibiotics, right? That was done. So we can, to me, it's implied to me that, okay, he was safe enough to send upstairs without having to have a norepinephrine drip, right? He must have stabilized with that first bolus. But now he's up here with me, and his blood pressure dropped again. This is what happens in sepsis. Their blood pressure drops again. So, and now we got this new information. That lactate, guys, is 12. We got a real high lactate. We got a real problem. So somebody said, yep, we could just go hang the norepinephrine. But I heard other people say, you know what? He got that first bolus, but now we see that high lactate. What do we do when the lactate's really high?
Fluid bolus.
We do
Fluid.
bolus. So, so we know before we even look at a test question, we know what we want to do. We want to either give another fluid bolus, or we want to hang the norepinephrine, right? All right, so let's look at our next question about this patient. What will the nurse do now? Give another fluid bolus and reassess? Administer a continuous insulin drip? Repeat the blood cultures? Or administer dobutamine?
A.
Give another bolus.
Give another bolus. All right. So somebody said they wanted to hang norepinephrine. Are you angry at this test question? Because norepinephrine's not here.
No, I'm not angry because it's not a choice.
Yeah, it's not a choice. So this is test land. This is the kind of the frustration that we all have when we're taking a test, because we knew what we wanted to do. Somebody said, "Oh yeah, it's time for a vasopressor," but for me, I'm saying, well, I now got the hard evidence how high that lactate is, and their blood pressure has dropped now again. So I'm thinking, they probably need a fluid bolus too. And what assessment might we do to determine if they're a fluid
Passive
responder?
layer raises.
That would be a great intervention, but that's not the test question. The test question is saying, what will the nurse do now? And they're not saying do a passive leg raise. So of these things, we just have to decide what is best. What's the best answer? And we all agreed. The fluid bolus, why do we say the insulin drip is a bad answer, that we're not taking it? Why are we not hanging an insulin drip on this guy?
We don't even have lab values of 180 for glucose.
We don't know his labs yet, yeah.
Yeah, we don't
Yeah.
know.
There's no
So
blue.
that we ain't biting on that one, right? What about repeating the blood cultures? Should we repeat the blood cultures?
We don't have them back
We
yet.
don't have the
We don't have
results.
them
No,
back
you
yet.
already started antibiotics.
Yeah.
Sorry,
And,
UTI.
and y'all, we already drew. They drew them down there in the ED. They already drew these blood cultures. We're not going to draw blood cultures 2 hours later. You know, these blood cultures haven't even grown out. It takes a while for you can't do blood culture stat. It takes a while for the organisms to grow to be determined. So no, we're not going to get another set of blood cultures. You know, we've already gotten our blood cultures. So are we good with that? And then why? And then administer dobutamine. Why are we not going to? I'm echoing.
Amira needs to mute.
So we're not going to give dobutamine because that's not what we're going to do now. Now we decided we're either giving a fluid bolus, we're doing a passive leg raise, or we're going to give norepinephrine. So that's what we think in our head. That's what we're looking for here. And the only thing that's matching the way we're thinking, the fluid bolus. So that's the way we're going. So sometimes you might get frustrated because you're looking for, you know, the answer that you have in your head. So whoever was saying do a passive leg raise, you know, it's not there. So pick what's best. So are we good with that? That's a real important lesson, a very good, important lesson for y'all to know.
Dr. Udo.
Yes.
So you would do, if you did vasopressor, it would be norepi, then vasopressin, and then dobutamine?
Okay. Not necessarily. Our first choice is to start, if we've got to pull out the vasopressors, we're going to hang the norepinephrine. Now, if we go up and up on the norepinephrine and they're refractory to the norepinephrine, or they're not responding how other patients respond and their blood pressure is not going up. So then we would get out the vasopressin and hang that at a set rate. And then once we do that, hopefully we could start coming down on the norepinephrine. But many times they may say, wow, we've got to get their blood pressure up, hang a bag of epinephrine. So we may have norepinephrine, epinephrine, and vasopressin going, just trying to figure out how do we get this blood pressure up? Which one of these does the patient like?
Do you still have LR going with all of that?
Yeah. So usually in our septic shock patients, you may see them having a crystalloid of normal saline or lactated ringers going at 125 an hour. You may see that kind of continuous fluid resuscitation going on these patients with septic shock. Normally, you know, when you see somebody with the IV, you see them going at 50 mils an hour, you know, but so, you know, they could be having lactate ringers or normal saline going at 125, 100 an hour. If we feel like the fluid volume has been replaced, we may only have them have fluids going at 50 mils an hour. Septic shock is when we've given them adequate fluid volume and we still can't get their blood pressure up. So you may see norepinephrine, vasopressin, and epinephrine being hung, or neosynephrine. However, if we're thinking, maybe, they need some more contractility, then the dobutamine would come. But we don't, dobutamine is going to come after vasopressors and the vasopressin.
Thank you.
All right. Now this is complicated and I need to probably, luckily for you, I don't have a test question that looks like this. But I want you to look at this diagram with me. In the ED, we had a patient that came in and we gave him a fluid bolus, a septic shock patient. They came in, gave him a fluid bolus at 30 mils per kg. All right. So this is what they look. Their stroke volume was 38. Is that high or low?
It's low.
It's low. That stroke volume is low. We expect a stroke volume to be 50 to 100 mils, right? Per stroke. So this is a low stroke volume. And our cardiac index?
That's
2.5, huh?
That's low.
Okay, what did we get our norms of our cardiac index?
2.8. 8 to 4.2, I think.
Okay. And then, but when we get down to like 2.1, we're thinking cardiogenic shock, right? That's what we think, when we're talking about cardiogenic shock, right? But your cardiac output and your cardiac index will also go down as your sepsis continues. So we're low. Our systemic vascular resistance is low, right? 600 dynes. Our heart rate is compensating, and our blood pressure and our MAP are low. This is septic shock. All right. So now we decide, well, let's raise their legs and let's see if they're a fluid responder. We did a passive reg legs, and then what did we see? Really, stroke volume didn't come up. Normally, you would see that come up after a passive leg raise. Cardiac index, really no change, no significant really change in afterload. Your heart rate, no significant change. So do y'all think that this patient looks like a fluid responder?
No.
No, nothing improved, right? So what are we going to do?
Norepinephrine.
We're going to take that norepinephrine. Now, I'm sorry, I copied this slide from a webinar I went to, and at their hospital, they hang norepinephrine. The trade name is called Levophed and mics per minute. But I test, the book talks about mics per kilogram per minute, and many units are hanging norepinephrine and mics per kilogram per minute to prevent medication errors. So just bear with me that the norepinephrine on this slide is ordered in mics per minute. But the norepinephrine's going, okay? So now an hour later, this septic shock guy, we look at their stroke volume, and it's now 46. Cardiac index is worse. Our afterload is still about the same. They're still dilated. It's still low. They're still shocky. Still tachycardic. Their MAP is low. Their blood pressure is low. So what did we do?
Vasopressin.
We went up. We titrated up on the norepinephrine. So we started at a low dose and we titrate up on the norepinephrine. Because our titration orders, you're in control of based on what their MAP is. Right? So if their MAP was 60, we need to titrate up, don't we? Because we're not at a MAP of 65 yet, right? So we know we got to titrate up. We don't call doctors to say, hey, would you like me to titrate up? These are our orders, and we are to titrate up every 3 to 5 minutes until we get that MAP at 65, right? So you don't need to, if the MAP is 60, would the nurse call the doctor? No, the nurse is going to titrate up. We have the orders to titrate up.
How long could norepinephrine be hung for? Because you said that it starts turning your fingers and toes black after a certain point, right?
I was having a hard time understanding you. I'm sorry.
How long could you hang the norepinephrine for? Because after a certain time, it starts making your fingers and toes black, right?
Oh, we can hang norepinephrine for days, days. Yeah, you're trying to save their life, and you have to help with the perfusion, fluids, and vasopressors, and that's why that woman that I talked about that graduated from Charity, Cassidy Pressamon, she walked out of there with her life, but she lost legs and arm and hand, so um it's a tragedy. So we have to deal with all the amputations that are going on daily from sepsis survivors. So, but we titrate up. We see our map is still low. We know we have to titrate up. All right, so now we do a passive leg raise. We want to go, I wonder if this guy needs some more fluids. So they had a stroke volume of 46. Now they have a stroke volume of 48. Cardiac index is still low. Afterload's still low. Heart rate. So we're not seeing much change, right? And then my blood pressure's still low and my MAP is even worse. So now it's like, well, we went and said, okay, let's try hanging some vasopressin to go in conjunction with our norepinephrine. So let's see what happens now. We look at the patient an hour later. Stroke volume is still low at 40. Cardiac index is very low. Our afterload is looking a little bit better. So, ooh, good. That vasopressin is helping with the afterload. The heart rate that tachycardia is coming down some. And look, our blood pressure has come up some. So that's cool. And our MAP is 66. So do I need to go up on my norepinephrine?
No.
No. So I'm not going to titrate up on my norepinephrine. We look like we're at a good spot. We're at our goal. So I'm not going to titrate down, not going to titrate up. I'm going to keep it right where it is. I'm going to keep that vasopressin right where it is, because the vasopressin plus the norepinephrine look what it did to my afterload. It brought my SVR up to a low normal. Right? So now we raise their legs and we do a passive leg raise and we see stroke volume 42. This is low. So my cardiac index is still low. And y'all learned that cardiac index, like less than 2, we're thinking cardiogenic shock. And it's looking like cardiogenic shock. My afterload is a little bit better. Heart rate's okay. My MAP is still 68, so I don't need to go up on my Levophed, on my norepinephrine. And this vasopressin is just a set rate. But now look, because of my cardiac index at 1.9, we think, oh, let's give dobutamine. Let's give it a try. So now we give the thing that increases contractility. So 2 hours later, we go look at them, and what do we see about our stroke volume? It's finally normal. It's finally 50. Cardiac index, did it go up? Yes. How's our afterload? About the same. Heart rate is tacky again. Uh-oh, what happened to my MAP? It went down. So do I need more vasopressor or do I need more fluids?
Fluid.
Well,
Fluids.
let's do a passive leg raise. So we're going to do a passive leg raise and we look and see, ooh, that brought my stroke volume up. It brought up my cardiac index. It brought up my afterload. Brought up my MAP. So let's give them a 500 bolus. So you see, this is how with septic shock patients, we're constantly reassessing them. And we're looking to see, Are they a fluid responder? Do we need fluids? You know, where's our map? Do I need to titrate up on my norepinephrine? So that's kind of how a nurse, you know, does, you know, manages their patient. We talked about how to prevent a post ICU syndrome with all those wonderful things. And then here, I'm just going to end on this one. The patient is lethargic. Now, lethargic, just when somebody's lethargic, picture them slumped down, having a hard time lifting their head and lifting their eyelids, right? All of you are sitting up, your eyes are alert, and you're learning and you're processing information. None of you are lethargic, right? You all have Glasgow coma scores of 15. The patient is lethargic. Something's wrong with them, right? They're septic. They're in the ICU post infusion of antibiotics and additional 500 ml fluid bolus. Now we got new assessments. The MAP is 60. The norepinephrine infusion is at 1.2 mics per kilogram per minute. The most recent lactate is back 4. Respirate's 23, heart rate's 83, and temperature's 100.8. What's the Q SOFA?
3.
Okay, how come it's a 3?
The level of consciousness with the lethargicness is a 1. MAP being 60 means low blood pressure. That's 2. And the respiratory rate is 23. That's 3.
Yeah. All right. So very good. It's the Q SOFA score. All right. So with the same question, I could say, how many SIRS data are evident?
The temperature, the heart rate.
It would be 2.
2.
Temperature, heart rate.
Yeah, 2.
Yeah. Yeah. So they have a SIRS that there's 2 SIRS data evident. Good. We're all speaking the same language. We're
Dr.
all
Udo,
yeah.
the SIRS was based on the temp and the respiratory, not the heart rate, right?
Correct.
Okay.
Why wouldn't it be 3?
Because the heart rate would have to be greater
Oh,
than
Greater than 90.
I didn't see that. Sorry.
using the SIRS criteria. All right, and then which intervention is increasing the patient's afterload?
The
norepinephrine.
fluids.
The fluids and the norepinephrine.
The norepinephrine. The norepinephrine is the vasoconstrictor that is increasing that SVR, increasing the afterload. Very good.
I have a question about the Q SOFA. So, the blood pressure criteria was below 100 for systolic blood pressure, but you would accept MAP at 60 as well?
Yeah, but just because if the MAP is 60 and they're on a norepinephrine drip, do they have a good blood pressure?
No.
No. They're in shock and they can't get a blood pressure up. They're hypotensive. So we're now infusing norepinephrine. Right. So you know that blood pressure is low because if we turned off that norepinephrine infusion, they would have like a systolic blood pressure of 40, right?
Dr. Udo.
Yeah.
Dr. Udo, for the Q SOFA, I understand why you're saying with the MAP is 60, but I thought it was only if the systolic blood pressure was less than 100. So we using the MAP as the way of determining that?
Do you think that this patient has a systolic less than 100? The MAP isn't even 65.
Yes.
So it's just to make you think. It's just to make you think. Like on my test questions, I just want to make sure that you know the stuff. I'm gonna put in there your SIRS criteria, your Q SOFA, but you need to think about this. If this person is on a norepinephrine drip, their blood pressure is so low that they can't maintain circulation. So we put them on a norepinephrine drip. So you can imply that they have a point for the low blood pressure. Dead silence.
So that's just if the MAP is under 65 and they're on pressors, we're to assume that the blood pressure, the systolic, is less than 100.
Yeah. Now, we use the quick SOFA to identify sepsis early. So this patient in this situation, we're really going to get out the full SOFA score and use that big table to figure out their full SOFA score. Quick SOFA is to help us identify sepsis early. We already know this guy's septic. So now we're, if we pulled out the big 0 column and go over to the far right, we see, if the MAP is low and we're having to hang, vasopressors, they're getting all kind of score. They're scoring a 3 or a 4 on the big SOFA, on the full SOFA. What else? Yeah. So this is just to make you think. It's an implied, if they're on norepinephrine drip, they don't have a good blood pressure. They don't have, their systolic is below 100. Can we all agree on that?
Yes.
Right. So what is the priority assessment at this time? Priority assessment.
Can we see if they'll respond to fluid?
Yeah, I think so too, because we just got a lactate back and it's still 4. And we know that, we get these lactates and, when somebody comes in with lactate of 4 or higher, we want to bolus them, right? But this is a guy that we've been treating. They're in septic shock and their lactate's back at 4. We want to see, I wonder if they're fluid responsive. So fluid responsive. So what will we do? What's our priority assessment?
Passive leg raises.
Yeah. I'm sorry. Yes. Yes. I don't want to share. I want to unshare. I'm trying to stop share. Awesome. Are y'all exhausted? I am.
Dr. Udo, what range did you have for stroke volume for the test? Because I thought you said a range that different than what I had.
A range for what?
Stroke volume.
So whatever y'all learned in perfusion 3, did y'all learn 50 to 100 or 60 to 100?
60 to 100.
60 to 100.
And that's fine. 60 to 100 is the normal stroke.
Thank you.
Dr. Udo, I have one question. If the patient, one of your questions, if the patient is on a vent, can we assume their Glasgow Coma scale is less than 15?
No.
No. Okay.
No. You have to remember every day that they're on the vent, we're going to try to wake them up and see if they can breathe. So we're going to turn off the fentanyl. We're going to turn off the propofol. We're going to turn off all the sedation, all the analgesia. We're going to turn it off and wake them up. And then we're going to see if they can breathe. When you turn them off and wake them up and get them to breathe, that's when you do your neuro assessment. And I've seen people, especially during COVID, I've seen people on the ventilator that were wide awake. That we were ambulating them on the ventilator around the room while we were waiting for a lung transplant. Wide awake, following commands, doing crossword puzzles on the vent.
Okay, thank you.
Yeah. Did we get Teresa?
Can you hear me?
Yes.
Oh, good, because I didn't move from this phone.
The floor is yours.
All right. Okay, guys. I don't know if I can add anything to your brain right now, but let's make it kind of simple. On disaster, we had 4 phases. You have to know those 4 phases. And the first one was mitigation, right? That's when you're planning. Preparedness is when you're setting up your family plan, you're checking your equipment. Response is when you're doing direct care to those victims, like the Cajun Navy, everybody's coming in. And recovery is when we have new things built, like new buildings. Your role. Can you practice outside your scope? No.
No.
Can you allow family members to give medicines during a disaster?
Yes.
Yeah. Yes.
Do you always have to have HIPAA?
No.
No.
Can you compromise safety?
No. No.
Are you responsible for the ANA standards of practice?
Yes.
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 If you delegate to someone, are you going to give that person the easiest patient or the most complicated patient?
Easy patient.
Easiest one.
All right. So let's move on to triage. What we learned, regular triage is, right, you're treating the sickest person first in the ED. Reverse triage is on the outside with a disaster. And it's the exact opposite. We want to save as many people as we can. Are you going to use your supplies on the sickest people?
No.
No, you're going to use all the supplies up.
Right. Okay. Going back to the video that was in class, basic principle. What did the guy assess first when he came in?
Walking wounded.
Patient who can walk.
If you can walk, if you can walk.
And the
If
entries
he can
and exits.
walk. After he got all those people out, then he started putting tags on them, right? And what does a black tag mean?
They
And
dilated.
They
They
deceased or more
dilated.
likely to die on the scene.
Like that. Yeah.
Good. All right. What about red? We had to go back to that rule on red, right? Your RPM. So if you had a person and his respirations were greater than 30, is he red?
Red. Yes.
If he cannot respond to anything that you ask him, is he red?
Yes.
Yes.
If he can obey a simple command, but he's a little confused, is he red?
Wouldn't he be delayed?
No, he's yellow.
He would be yellow. Yes, you're right. Delayed, yellow. Okay. He can wait a little while. And green, no matter what, they can walk. Now, when are you, the first thing you're going to do, remember the buts. The ones that could walk were assessed first. After you've assessed all your walkers, then you come back and you figure out your red and yellows and blacks. Okay? Your red would be the one that would come next, would get the next ambulance. The yellow would get the next ambulance. And the black would get the coroner. Now, if you had one of these really bad disasters, what do we call those things that you should have after a disaster? What's that talk called?
A debriefing.
Debrief.
Okay. And in the briefings, do we discuss what you did wrong, or would we discuss what you could do better, or would we discuss your feelings?
Your feelings. What you can do better.
Okay. The other would come a little later. That's not the time to do that, to figure out, what you did wrong. All right, let's move on to biological weapons. We had 4: anthrax, smallpox, the plague, and botulism. Anthrax, ISO or no ISO?
No.
No.
Contact.
Where does it come from?
Mineral
Animals, the
ground.
The ground.
Okay, infected animals, right? We had to remember about the farm people, the livestock people. So, if you had a patient that had anthrax, a lot of these people are going to be like dehydrated. So if somebody's dehydrated, what are we going to give them?
Fluids.
Fluid. There's also a treatment for anthrax, and it's it's Cipro 400 CID. You can also give Doxy, and you can also give penicillin, but Cipro is the one that you give, and believe it or not, it's for 60 days. So,
can you repeat those again, please?
Just Cipro is going to be your major one. If you don't have Cipro, they can give penicillin or they can give Doxy.
What was the dosage again on the Cipro?
400.
And you said for how long?
CID. It's going to be a long time, 2 months. Can you imagine being on Cipro for 2 months? All right. Smallpox. Remember what we said about smallpox. What's it look like?
Red blue light, red spot.
And they're drained up. So if you have somebody that came in looking like that, what would be the very first thing you would do?
You will get
isolate that
your own
person.
PPE. Get your own PPE to protect yourself.
You want to always protect yourself. The second thing you could do would be
Isolation.
Isolate that patient.
Okay.
Wait, Ms. Dickerson, I'm sorry. It's hard to hear everyone talks at once. Can you describe what the smallpox looks like?
It's got sores all over it, pustules all over. Sometimes they're draining. And you can get this by contact. You can ingest it. You can get air. You don't want smallpox. That's why it's under lock and key. And the only 2 countries that have it, supposedly that have it, is Russia and the US. So think about this. If it's that dangerous, you definitely want these people in a negative pressure room, right? And you definitely want PPEs on you. The plague. Where does the plague come from?
Fleas and rats.
Okay, what's the big thing about botulism that we worry about?
Respiratory.
Okay. Those are the people that are going to have, respiratory is going to be neurological things, right? You're going to see them stiff. Remember the baby that was all stiff up? comes from canned food, can come from a contaminated wound. Now, with all of those 4, which 2 are you going to put in isolation?
Plague and smallpox.
Plague and smallpox.
All right. I don't have to worry about y'all giving me smallpox then. Let's go to you just had an explosion. What's the first thing that you want to do to get rid of some of that contamination you have on your clothes?
Take
them
off.
off.
And shake them out.
And shake them out.
Okay. How much does it remove?
90%.
90%.
A lot. That's why you want to definitely take it out. So if you are contaminated, and we're going to have to wash you down, what kind of soap would we use? Are we going to scrub you?
Mild soap. Non-alkaline.
Mild. Are we going to scrub you and get all that mess out of your wounds?
No scrubbing. No scrubbing.
All right. Now, going back, there seemed to be some confusion in this from some students. This is for nuclear radiation only. You perform your life-saving care before you decontaminate them. Why? If you're washing them all down and they can't breathe, you just wasted all that time washing them down, because airway needs to be done on these people, or they need to be moved or something, to that effect. We're not going back to triage where we said, don't start CPR. This is for radiation. So if you've got a whole bunch of people there, if you've got someone and his leg is cut wide open and he's bleeding out, you're not going to wash this guy down and decontaminate him. You are going to put something on that wound, some pressure on that wound to stop him from bleeding. Do you guys follow me on that? I just make it perfectly real clear so that you don't, if I'm not breathing and we had a nuclear attack and the building fell on me, I might die of radiation poisoning, but it might be a year from now. But if I can't breathe, I'm going to die in 2 minutes. So, and gosh, I'm glad you guys got this. I want to be sure that y'all were in a disaster with me. But
thank you.
Hopefully that's cut and dry and simple, and you should be able to know what to do if you went to school tomorrow and something happened. Hopefully that never happens, but you should be able to know how to handle these things. Got it?
One question. What was the debriefing for? The answers were kind of muffled.
Anytime you have a debriefing, you're usually going to discuss how did you feel today? Kind of like we do in post-conference after clinical, and you had a really bad case. Your patient died. How do you feel about that? If they had a fire and children died in the fire, the firemen have a debriefing, because you've got to get that out. You've got to get those feelings out. Now, something I wanted to tell you is going back to some of these choices. When you have a choice on a question, look at it and see which one of those is what I would call an umbrella. It covers all of those answers. That'll be the answer that you would pick, such as an example. Patient has a temp of 100. Check vital signs. Patient has blood pressure 100/60. That check vital signs covers all of those. The easiest way I can describe it, if you come to a question, not so much on these, because this is pretty concrete, I think, I hope. But for other things, look at what is the umbrella that would cover all of those. And it might help you pick out an answer if you're stuck between two of them. So, I don't guess any of you guys are going to get reported to the Board of Nursing, since y'all know how to do all this stuff for disaster. Okay. I think that just about sums it up. I know sepsis is a lot harder than this and takes a lot more. This I tried to keep real cut and dry to where in a year from now, you'll remember it, I hope. Any questions?
Please answer the poll before you log off too. Thanks. Sorry.
Any questions? No. I can't see anything, y'all. I can't see the chat. I'll be at school tomorrow, so if you have anything, let me know. Any questions that I can answer?
Yes, for smallpox, besides giving them like antipyretics and those type of things, do we give them any antibiotics or anything?
That is more or less supportive care for the smallpox. It's going to be more of a general thing that you're going to treat them for however they feel, anxiety, pain, fever, fluids.
Thank you very much. That answered my questions.
Catherine asks, what is strict isolation? Negative pressure, room, all the different precautions combined? So she's asking a question.
For the plague.
A regular ISO room, if you're calling just a regular ISO room, they sometimes don't have negative pressure. They just have one room that they put in there and they're calling it ISO. That's not what I'm talking about. If these people get this, you're going to put them in negative pressure rooms. If you have them, you probably won't have them. So if you don't have them, you're going to have to put them in an ISO room. I just want you to know that these people can't mingle. Not going to leave these people sitting in the waiting room.
And then they're going to be in isolation rooms for the plague, but what are we wearing everything, gowns, masks, gloves, everything, like all the...
If they're in ISO for these things, it's going to be all PPEs. That includes everything.
Okay. Thank you so much.
I'm not gonna go and ask you things like, do you need an N95 mask versus a mask? Do you need gloves versus, I just want to know that they got to go in an isolation room.
Thank you.
Because I don't want to catch it.
Thank you.
Y'all got it?
Thank you.
Yes, thank you.
Thank you so much for doing
Thank
this.
you.
Faculty, hang on after everyone leaves, just for a minute. Thank y'all for attending.
Thank you.
Thanks.
See y'all tomorrow.
Thanks, everybody.
Good
Take
luck.
care.
Wait, I do have a question. I sent Dr. Udo a message. Dr. Udo?
Yes.
I was wondering, when do you withdraw the ProCal?